What's up, guys? Welcome to episode 8 of the League Trauma Podcast, where we talk load tolerance, clinical relevance of a CSCS, and misconceptions around the profession of physical therapy with Dr. Erik Caplan. Dr. Caplan is a physical therapist at Beatty Harris Sports Medicine who enjoys treating all orthopedic and sports-related conditions. He is a certified strength and conditioning specialist who has a background in training individuals of all ages and skill levels. Dr. Caplan provided us with great insight on entering the world of PT as a new graduate, and we have been very fortunate to have the opportunity to make this episode possible. We appreciate Dr. Erik Caplan for sharing his time and expertise with us, and we can't wait for you all to check it out.
Yeah, my name's Erik Caplan. I'm a physical therapist at a private sports medicine practice called Beatty Harris Sports Medicine. My background is generally in orthopedics and sports medicine. Before that, I did some personal training, strength and conditioning coaching, sports performance. So I worked in that world before PT school and also during PT school, and I do a little bit of it privately still. But just with how constrained time can be, I'm not doing it quite as much as I'd like to be. So I very much intertwine it into my practice, but I'm not doing any strength coaching in a formal setting anymore. But that's kind of my background. So I've been with Beatty Harris now for probably coming up on like 7 or 8 months, and I was in a different larger orthopedic practice prior to that. So yeah, orthopedic sports medicine is kind of the niche that I've worked my way into, and I really enjoy it.
Okay. Yeah, so my first question following off of that, I guess it's a little different because you said you were at another clinic before the one you're at now. Because I was going to ask if you could talk a little bit about like that first year out of PT school and what were some of the common challenges you face and what you do to get past them.
Yeah, being a new grad is challenging. I think that when you come out of physical therapy school, you have a lot of preconceived notions about what it is to be a physical therapist, and how you picture your career and how you picture your career starting. So you're often kind of looking at things through rosy lenses, and I don't think that's necessarily a bad thing, but I think that a lot of times once you hit that first year and you're hit with the workload and you're hit with productivity expectations and kind of working into your day to day where you're seeing a lot of patients and you're just trying to get your thoughts straight and you're trying to manage your time. It's challenging, and I think that what really makes it difficult is that a lot of times what you're seeing in the clinic is not necessarily what you learned through PT school and you're in the more formal educational setting. So you just end up seeing that things don't always fit a very specific paradigm, and that pattern recognition becomes a really important part of things where you need experience to find out when to kind of default back to your foundational kind of core training and when to deviate away from that when things don't necessarily go as planned. So it's really just getting used to dealing with a really wide variety of patients and acknowledging that sometimes patients aren't going to fall into a really specific category. People are really complicated and complex, and a massive part of physical therapy is just learning how to communicate with people and learning how to navigate the ins and outs of a person's psyche rather than just worrying about what's going on with their physical body. So everybody's so unique, one person to the next, and I think getting a really good hold on that is probably the biggest challenge. But I also think that having some experience going into my career, having had somewhat of a career prior to entering physical therapy, I feel like I was maybe a little bit of a leg up just because I had worked with people, and I worked with managing people's problems and managing people's goals. So I felt a little bit more comfortable maybe going into that first year, but regardless of that, physical therapy is very different than personal training and strength and conditioning and working in sports performance. So you're going to encounter a lot of complexity in PT that you probably wouldn't elsewhere.
Yeah, I know a lot of people tell us when we're looking for that first job, a important question to ask is like, what's your mentorship program like? Because like that bridging that gap between school in that first year could be a big step. So
Yeah. No, it totally is. And I think mentorship is absolutely crucial. And I also, and this is kind of unfortunate, but I think a lot of bigger PT companies will make promises about what type of mentorship they offer, and they don't always follow through with that. So I think a major consideration as you're going into your first jobs is to not only ask the question, but ask more detailed questions. Find out what that program should look like, and if they're not holding up their end of the bargain, you need to be finding out ways to access the resources that they're promising you. Like don't let it slip through the cracks just because it doesn't seem to be fitting into your day to day. Find a company that really values mentorship, because it's absolutely critical to your development as a PT. And if you're finding that you're in a company that doesn't offer a really structured, in-depth mentorship program, that doesn't necessarily mean that you need to abandon ship. But I do think, if you're noticing that it's probably worth finding other ways to seek mentorship. Honestly, I feel like I've always been indirectly mentored by the people that I follow through podcasts and through reading. Um, I I think that having those resources accessible to you at all times is really important too, because you're going to find that you're going to gravitate towards specific people that have somewhat of an online presence, and they're putting out good content. And I think latching onto that information as guidance is really important too. And I've had a lot of success pursuing mentorship that way.
cool. Thank you.
Yeah.
So diving into a little bit about like your personal training background and like because like Josh and I are both athletes, we both had lots of experience with the strength training and how that kind of works.
Hmm.
Like personally, I feel like the hardest part about for like translating that to PT is the regression part. Like when patients need to regress their amount of volume and intensity that they're doing in therapy. Did you have a
Hmm.
similar experience with that? And if so, how did you kind of like mesh the two together and overcome that little hump?
Yeah, I mean, it's a big challenge in both settings. I consider in a lot of ways as more of a sports oriented therapist. I look at a lot of patients as strength and conditioning clients in the presence of an injury is really what it comes down to. It's how can it's looking at a person's goals and making sure that the treatment that I'm providing them matches what it is that they're seeking, and not letting my goals for them get in the way of what the treatment really is, and what the treatment's supposed to be for that person. So, it really depends. Going back to your specific question, it really depends on the person. I try to treat everybody like an athlete in some ways, because it's probably my bias and it's just what I'm comfortable with. But I also find that that's really effective for people. So, I really try to find where people's thresholds lie, and try to work them into their upper thresholds and get them comfortable there. Because I think when you set that precedent and you kind of teach people what it is to put sincere effort into their rehab, I think that the process tends to go a lot more smoothly. So, if you encounter a situation where you're working with someone, and you've pushed them a little bit too hard one day, and maybe they wake up the next day and they're really sore and they weren't ready to be that sore, or maybe they had somewhat of a flare up because we pushed beyond the thresholds that we've tried to establish. I think that the first thing is to just very clearly communicate, the fact that physical therapy in a lot of ways can be a process of identifying tolerance and working up to that tolerance, and in some cases you're going to overreach a little bit. And then you just have to have a process in mind for how to kind of regress back. So if you have some experience with prescribing exercise in any capacity, you know that it's important to have one, two, three progressions from an exercise and one, two, three regressions from an exercise. And it's important to have both ends tied up pretty tight, because in the event that someone is flared up or they are dealing with excessive soreness, you need to be able to dial back exercise, but keep the same goal, active as you're doing that. And that can be challenging, but it really is something you have to take on a case by case basis.
And you mentioned communication. Are you communicating to your patients that you are treating them like athletes? And if so, like how do they kind of respond to that? Do they enjoy being treated like an athlete, even if they aren't necessarily like your typical athlete?
Yeah. I mean, I see very general orthopedic. So I have 12 and 13-year-olds, and I have a 100-year-old on my caseload now. So when I say I'm treating people like athletes, that doesn't mean I'm getting the 100-year-old on the turf strip and having them do like agility drills and stuff like that. It just means that I'm using concepts and principles that I have derived from strength and conditioning experiences to kind of inform what I'm doing with patients. Um, so concepts like developing load tolerance versus developing strength, like what are the differences between those two things? For the 100-year-old that has a hard time getting out of a chair, that exercise prescription is going to look a lot different than the strength athlete that comes in that's trying to improve their squat with back pain. So I'm still employing the same principles in a lot of ways. I'm just doing it in a very different way for a very different purpose. So I want to educate the older patient who's maybe elderly and frail. I want to educate them on why we're using strength exercises and how we're going to progress strength exercises, and that some exercises are intended to be very task oriented, while others are intended to develop muscle and hypertrophy and properties of strength and power. So I make those intentions very clear, but I also make it clear that sometimes, like, if you're just trying to get up from a chair, maybe we practice getting up and down from the chair, and that's just what today is. So I think it's not necessarily about, telling someone that, like, hey, like, I have some background in strength and conditioning, I have an interest in sports, so you're an athlete today, even though you didn't come in planning to be one. It's not necessarily that. It's more just using those principles to my advantage as I'm taking people through their treatment.
Awesome, that's a great point. Thank you.
Yeah, sure.
So my next question is pretty general. I was just wondering, what are some of the common misconceptions that you often hear regarding physical therapy?
Yeah, that's a great question. You're going to run into questions like when you get into practice. You're going to run into questions every day that are hard to answer, because people always come in with their own baggage. They come in with their own preconceived ideas and preconceived notions about what therapy is going to look like. And sometimes that's based off of their own past experiences in physical therapy, or sometimes that's what they've heard about physical therapy, or what they're expecting from physical therapy. I think one big one is that comes to mind right away is that you have to get stronger if you want to not have pain. It's one of so I was talking about, strength versus load tolerance a couple minutes ago. Um, this is one of the biggest, and it's really basic, but it's one of the biggest epiphanies that I had as a therapist, is that um, you know, a patient comes in with knee pain, we're using strength exercise for that patient as a treatment vessel, but that doesn't necessarily mean that if they don't get substantially stronger than they are right now, that means that they're going to continue to have pain. So we're using strength exercise as a way to build resilience and build tolerance. And strength is probably an emergent benefit that comes out of that, but that doesn't necessarily mean that person has to come in and crank up the weight every single time they walk through the door. And the reality is that a person with an injury or a person with a specific condition might not be able to crank up the weight every single time they walk in the door. So I think sometimes people walk in, whether they're a high level athlete or they're that 100-year-old patient that I've been seeing, with the expectation that my back really hurts, and I've heard that if I can't lift a weight up off the floor that's 50 pounds, that it's always going to hurt. It's like, I would love for you to be able to do that, but that's not necessarily the gateway into you eliminating pain. Pain is super, super complex, and you're going to find that the more that you work with people in pain, it's really complicated, and it's not just about getting stronger. I think at a really fundamental level, it's about building tolerance, and it's about building resilience to stress being passed through the body.
No, yeah, that's a really good point. Like, the more you would say that, I feel like maybe even like me myself has had that misconception that, like, somebody has knee pain, maybe we need to get that knee stronger. But the way you put it in terms of tolerance and just building that load tolerance, that's something that's really important to focus on.
Yeah, I mean, you're gonna have patients every now and then that they come in, they've had knee pain for, like, and this is like best case scenario, of course, but they come in, they've had knee pain for 6 months, like anterior knee pain, super common. They come in, you give them one exercise, and they're like, oh my God, like I feel 80% better. I've never done this before. I've never seen this exercise. I can't believe how much better I feel. You didn't make that person stronger in 10 reps. That's just the reality of it. But what you did do is that you inspired some confidence. You gave them autonomy to deal with their problem on their own. You allowed them to kind of desensitize the troubled joint against some type of physical stress by using a specific movement, and you had a really good effect from it. And sometimes it does work that way. It definitely doesn't always work that way, but it illustrates the point that sometimes it's not the emergent property of strength that's beneficial. Sometimes it's just the fact that you've had all those other variables kind of worked out and working in your favor.
Very cool.
So Josh
Yeah.
and I are both in our first full-time clinical, and like you were saying, like everyone experiences pain different. Do you have any suggestions, like as we're going through our clinicals, like maybe some questions that we could ask our CI or just in general to PTs that like how they kind of deal with pain, and like if it's very it's very individualized, we know that, but like is there any questions that we should like be conscious of during our subjective portion of our eval that we can kind of focus on to get the best idea of how they're experiencing the pain?
Yeah, like I said, I mean, everybody's really unique and everybody experiences pain differently. So I think education on pain is really important, and educating yourself on the way that pain works is really important. The reality is that we probably know, like, you know, we've barely scratched the surface when it comes to pain science and pain research. There are some really good researchers out there that are doing great work. There are great PTs that are working in the kind of like pain science field to integrate that into practice more seamlessly. Um, but I think at a bare minimum, you just have to communicate with people, and you have to get the whole story. There's nothing more important in an evaluation than a good objective or a good subjective, and that's I feel really strongly about that the more you can gather from somebody, the more that you can connect with someone, the more that you can communicate in a positive way, the more information that you're going to get, and the more useful information that you're going to acquire. You might find that some people have more of a psychosocial problem than they do a physical problem in some cases, and you've probably seen these patients in your full-time clinicals that some people are just really scared and they're uncomfortable and they've never had an injury before, they've never had pain before. And if you want to talk about something that's going to ramp up your nervous system, it's anxiety surrounding an issue that they're having, surrounding knee pain that they're having. Maybe they have other stress going on in their life that's influencing the experience that they're having. Like all of these things are playing into the pain experience. It's not just about the biomechanics of the knee or the biomechanics of the shoulder. Without a doubt, those things are important and they're influencing the way that the person feels. But when it comes down to it, there are so many other factors that can influence the way that pain is manifesting and the way that they're experiencing that pain. You just need to be able to communicate effectively enough to pull that information out of them. Because sometimes people just they don't even know what's going on, and they just need to talk it out. They just need to have that first conversation with you so that they can start realizing that, like, hey, maybe this is being amplified by X, Y, and Z. And it's not just about the fact that, when I go up and down the stairs, my knee hurts. Some people truly think that just because there are, a couple situations in their day to day that influence their pain, that's got to be the thing that's causing it. It's never that easy. And I think if you can educate people effectively on the complexity of pain, but doing it in a way that doesn't seem overwhelming, I think that's really important early on.
Yeah, something that my CI said to me today is some days you just got to be the therapist in the physical therapist. Like you just got to be that rock for your patients, and
Totally.
yeah, and some days you got to just scale it back and just kind of let them just talk it out and be there for you. 'Cause you never know, like you said, what's going on outside of
Yeah.
the clinic. So that's a great point that you make.
Yeah, I mean there's a subset of the population that you're going to see that just need permission to be able to move again. And there are people that benefit from you just saying, like, movement is not going to make your problem worse. Exercise is not going to make your problem worse. It'll probably only help. You have some stuff that came up on an X-ray, you have some stuff that came up on an ultrasound, but you can do X, Y, and Z, and you have full control over that. And I think once people start to feel like they have control over their problem again, they start realizing that their pain is way less apparent and less amplified than it was when they walked in the door for that first time. So you can make a massive impact with a couple good points. And I think that everybody should that's in this field should take advantage of that, because that can be more influential than any exercise that you give that person.
Awesome. Thank you.
Yeah.
Yeah, it makes me wonder, like, it's a difficult topic because I feel like insurance companies and stuff are so driven by results and outcomes, but like sometimes you need to like step back and take the time to really encourage that patient to fully buy into what you're trying to do. Because if you can't get them to fully buy into what you're trying to do, then like how can you even get the outcome? How can you get those results? So that's something I feel like we will probably come up a lot. And I don't know, how do you deal with that?
Yeah, you just have to know the person that you're dealing with. Like if you're talking about buy-in, I think getting to know the person first and designing your treatment for that person is critical. I can't remember who said it. I think it was, I'm not even gonna guess, but there was a PT podcast that I was listening to one time, and the therapist said that the most important thing you can do on your first day with a patient, that initial evaluation, is just to become friends with them. Like that's priority number one. If you can establish that and you can make someone feel close and comfortable with you and you can gain their trust, you will get all the tools and information you need to make that treatment really effective for that person. So again, that's where your buy-in comes from. It's not about a cookie cutter program that you think works best for that person. It's not about going back to your PT curriculum and saying, well, like you have this condition and that means we have to do these 3 exercises. It's not about that. It's about hearing what the person is saying and giving them what they need, and they will tell you what they need even if they don't know what they need. So if you can pull that out of them, that's where your buy-in is going to come from. You'll figure out what they need within that first hour eval. Or I mean, maybe it's not always that easy, but you'll figure out what they need early on, because you're going to have good productive conversations with them where they're just telling you like hey, I can't do this and I want to do this, and if I can do that, I'm going to feel a lot better. And that's huge for people.
Yeah.
Have you had any experience with this buy-in part, like from any like interprofessional not consequences, but like interprofessional difficulties that someone else, like maybe their pain doctor or their surgeon, is telling them like, oh, you will never be able to feel good again. You're having this bone on bone is another thing that I kind of see on the reports. Like, how do you go about dealing with that? Is it just mainly communication, or because you don't want to step on the surgeon's feet and everything? So kind of talk about how you deal with this kind of stuff.
Yeah, it's huge, and it's probably one of the bigger obstacles. Going back to, I think it was your first question about challenges in your first year out of school. That's probably up there as one of the bigger challenges, is respecting other healthcare professionals whose approach and whose opinion you don't necessarily agree with fully, and not telling a patient that the other providers that they're working with are incorrect. Because chances are everybody that a patient's working with, that whole team, there's a good chance that everybody's not always going to be on the same page, and that sometimes you have to find the common links, and at its core, all of those professionals are trying to get the person better, and you have to acknowledge that. So like the bone on bone example is a great one, because every surgeon loves to tell patients that they're bone on bone. For some reason, it's like a weird badge of honor that they'll give patients, that this is the worst knee I've ever seen. I've never seen osteoarthritis like this before. This is terrible. I can't wait to give you a knee replacement. In those situations, I think it's very reasonable to unwind that when a patient comes in and they say like, hey, just so you know, my surgeon told me this is the worst knee you're ever going to see. So like, good luck trying to rehab it. Like you'll see a lot of patients like that. And I think it's very reasonable to be very upfront with that patient and tell them that like, hey, you're probably not actually bone on bone. There's a decent chance you got some good cartilage in there. I know it hurts a lot. That clicking and crunching you hear probably is not your bones smashing together. And I think saying that is just you being honest. I don't think that's stepping on anybody's toes. I don't think any surgeon, even if they disagree with what I'm saying, is necessarily going to be hurt by the fact that that opinion, right? I guess I don't think it's an opinion, but I don't that idea is being conveyed to a patient. And again, like those unwinding those little things here and there can make a huge impact on the way that a person's interpreting their injury or condition. So talk about like ways to decrease anxiety really on. Telling a person that their knee is not, two bones smashing together every single time they walk up and down the stairs. Like that's buy-in, and that's a way to reduce fear and anxiety really early on. But again, it's about being honest with patients. It's about not slandering other healthcare professionals for articulating and explaining things in a certain way, and just being respectful of other people's opinions, but also stepping in and saying like, hey, I hear what they're saying, but here's how I interpret what's going on here. And I think that that's a good way to do it, where you're not necessarily throwing anybody under the bus.
Awesome, thank you.
Yeah.
I just wanted to ask, what's been your most rewarding experience as a PT so far?
That's a good question. I would say very broadly, it's just realizing that I have the ability to kind of do things in my own way and help people in a way that's kind of unique to my strategy. And I like the fact that I can push positive change and I can impact people in a positive way without doing without doing things in a way that was, predetermined and preset, that I can kind of be my own therapist and I can develop in a way that I think is going to be most productive and most effective for my patients. And it's fun. I mean, it's a lot of fun to be the therapist that you want to be, and to acknowledge early on that you're not going to know everything, and you kind of have to be a sponge, and you have to figure out how to filter in good information and filter out bad information, and that's really difficult. But I think if you can learn to enjoy that process of developing in that way, and just being open to making mistakes, you're going to develop quicker than the person that shuts down every time that an outcome doesn't go their way. So yeah, I think that's what's been most rewarding is just kind of getting to be myself. And I think the more that I develop, the more I get to be myself. And I'm very happy that I've been able to help people as kind of my own person. So it's been cool.
Absolutely. Yeah, I think that's a really good point.
Yeah.
The other night, we were getting ready to close, and there was one patient left in the clinic. And I think my CI might have been like typing notes or something. And I'm talking to the patient, and she's like, you're getting into the best profession in the world. You know why? And I'm like, why do you say that? And she's a retired correctional officer, and she's just like, look at your CI right now. He's kind of like just independent. There's no one on his back.
Mm-hmm.
Her saying that made me realize, like, yeah, like he gets to make his own decisions. He gets to do the things he wants to do with each individual patient. I think that's really rewarding. And like, yeah,
yeah.
you have insurance companies and you have a team that you work under, but like in the grand scheme of things, you're your own clinician and you get to do what you want to do in a sense.
Yeah, I mean, man, there's so much infighting in physical therapy. Everybody's got an opinion. Everybody's arguing about what the best way to do things is. It always feels like there's conflict in what people think is the best treatment approach. But I just wish that more people would step back and take a look at the profession, and look at the fact that you have such a cool opportunity to help people in a really unique way. Honestly, I think that PT offers some of the clearest paths towards helping people of any healthcare profession, and doing it in a way that doesn't, you don't need to prescribe medications. You don't need to worry about giving people injections and dealing with a lot of the negative consequences of those types of therapies. Like, you just get to give people something that they can go do on their own, that's free of cost, that will never cost you a penny, and can only help you in not only your recovery from an injury, but also improve your quality of life and improve your health. It's a really cool opportunity. And I wish people would take more time to appreciate that, because it is a lot of fun if you let it be a lot of fun. And sometimes there are things that get in the way of you really getting to fully embrace that. But it's a great profession, and you're going to love it once you're out there.
Absolutely.
I just have a quick question. We're got about 7 minutes left. I just wanted to know, like, if you were at, like, would you suggest a new grad that's interested in getting into like orthopedics and sports PT to get their CSCS?
Yeah, I think it depends on what you intend to do with it. So I got my CSCS right around, I guess it was before my first year. I had already been doing some personal training and strength and conditioning stuff just with my, my undergraduate degree in exercise science. And so I had a little bit experience going into it. And I got the CSCS to expand my knowledge of strength and conditioning, not necessarily to benefit my PT practice. And that was my perception at the time. But when I started using those principles with clients and then eventually using those principles with patients, I realized how important they are. A lot of PT curriculum does not cover exercise prescription in the way that it should. And it doesn't cover strength and conditioning principles in the way that it should, especially given the impact that it will have on your day to day. Much of your day is going to be prescribing exercise and progressing and regressing exercise and being very intentional and explicit with the way that you're doing that. So I think that the principles are really important. And I think that they're really, really applicable. So I think just for that reason alone that it's a great certification to get. It's by no means the end all be all when it comes to strength and conditioning education. There's a whole lot out there. It's very foundational, just like a PT education is very foundational. I think more importantly, probably than the principles though, is also using that to work with clients. And I got a huge amount of positive experience working with clients once I had my certifications. So I would encourage anybody that's in PT school or getting ready to go into PT school to, especially if you're going into orthopedics and sports medicine or have intentions to get a personal training certification. It can be a CSCS, NASM, ACE, whatever it is. It's not just the principles, it's also learning how to work with people and how to manage people's problems and manage their goals. I think that's probably even a step above just the principles in and of themselves.
Awesome. So we got about 4 minutes here. Do you have any questions for us? Do you have any wrap up statements that you'd like to say before we end here?
Yeah, I'll reverse the first question you guys had for me on you guys. What are your biggest what are the big obstacles and challenges and frustrations that you have with PT school right now?
I mean, we had a podcast the other day, and this is similar to that question in a sense. So we're both out on our first full-time clinical rotation right now. And there's just something, I mean, we're 1 week in, so sure, like I know we're gonna adapt more as the time comes along, but like there's some topics that our program specifically doesn't dive deep into until later in the curriculum.
Mm-hmm.
So, and one of them being the spine, and like we learn the anatomy of the spine, common conditions in our first ortho class, but in terms of like treatment and then also like the evaluation of the spine, we haven't taken a deep dive into that yet.
Mm-hmm.
And us both being in orthopedic clinics for our clinical, obviously we're seeing a lot of spine patients, a lot of back pain,
Mm-hmm.
neck pain, and I feel like that's been a big struggle so far in terms of just like trying to think like what to do on the fly, and we haven't taken that deep dive into those specific things yet. But other than that, I'd say I don't know. For me personally, it's time management in the clinic.
Mm-hmm.
Not sense like the things, because I like to do a lot of things outside, like do work on my own things. But when I'm in the clinic, I feel like that's been the biggest struggle for me, especially in like the orthopedic setting with multiple patients within 1 hour,
Yeah.
keeping up with the documentation, stuff like that. I don't know about John Allen.
Yeah, I definitely see time management. It's just the biggest thing is documentation speed. I'm
Mm-hmm.
like rewording things like over and over again, like, is this right? Is this right? I think documentation speed is definitely what's holding me back from the time management part. And then the school specifically, I mean, I know Josh can relate this too. It's just sitting in the classroom all day. Like, yeah, we're learning so much and stuff like that, but just sitting in the classroom, like from 8 a.m. till 4 p.m. it's got to be the hardest part for me. I don't have the attention span to sit there and sit in a classroom all day, but that's been the most difficult challenge for class wise for me. It's just long days of sitting there.
Yeah, I mean your lack of attention span in a chair is why you're going into PT, so that's totally valid.
Yeah, that's
Yeah.
huge. I'm so glad to be in the clinic, and I know we'll go back in the because we have a 6 week clinic, and then the very next Monday we're back in the classroom for a spring semester. So
Yeah.
it's gonna be brutal to going back.
It,
But
it's a
that's
tough transition, but you're in the home stretch now. You can see the finish line. You just got to tough it out a little longer.
yeah, absolutely.
Yeah.
Yep. Any other questions? Any other closing remarks?
I could probably ask plenty of questions, but I know we're kind of up at the end here, so we can maybe have a second one sometime.
Yeah, absolutely. And feel free to text me. I can relay them to Josh too. And then if there is something we want to talk about, we can definitely hop on again. We would love that.
Yeah, man. Thanks for having me. This is great. I think having an outlet like this outside of PT school, while you're in PT school, is awesome. It's a great way to learn from other people. It's a great way to develop your skill set. So I think it's great what you're doing, and I definitely encourage you to keep putting out good content.